Thank you for this kind introduction. I would like to thank also the committee for this invitation. This is my first time presenting this lecture, and it's going to be about skin of color. So I have no conflict of interest to declare, so let's start by voting. How many of you use laser to treat skin of color? You can raise your hands. I expected much more. Okay, perfect. And do you have any patients who developed complications of skin of color? After laser, you can also raise your hand, right? It's very common. Exactly. So this is why I developed this lecture, a little bit from my experience, a little bit from the literature, because actually, despite the fact that there are hundreds of treatments, maybe thousands of treatments that are being done on skin of color on a daily basis, there is still not enough scientific evidence in the literature to guide us in working with these challenging skin types. So I hope this lecture will benefit you regarding how to deal with skin of color, how to prevent complications, and also how to get the best results. But why is it so difficult treating skin of color? Do they have more melanocytes? As a matter of fact, no. We all have the same number of melanocytes. But the thing is, their melanin, their melanosomes are much larger. They have more epidermal melanin. And their melanocytes are more labile, are more fragile to injury. And they have also more reactive fibroblasts, which makes them more prone to get hyperpigmentation, hypopigmentation, and also scars, whether it's keloid and hypertrophic scars. So this takes us to my question, which is the title of this lecture, how to get best results and avoid side effects. So I'll start with the basics. So if you know the basics, it will be a good reminder. And then we'll talk a little bit about advanced stuff, some literature, some newest evidence, and then we'll conclude with the summary, okay? So we'll start with the first one, which is a given. Use the right wavelength. So we all familiar with this graph, right? So basically, people with darker skin, they have more epidermal melanin. So if we use a laser in this wavelength, which is the visible light wavelength, we have a very high absorption of melanin, okay? So if we compare, for example, if we use a ruby laser, which is 694, we will have more absorption by epidermal melanin in comparison to the 1064 and the YAG. So patients with darker skin, highly melanized skin, they absorb laser more efficiently. So maybe the safest option when we have patients with skin of color to something in the near infrared range, that like Nd:YAG or maybe 800 diode laser. Sorry. I can do it from here. Perfect. Yes. So let's look at this picture. What happened here? So basically, they use a different wavelength. They use the 755 electron dry trail for hair removal, which is not the suitable option for patients with a skin type 6. If you have a skin type 6, you have to use something safer, like Nd:YAG, with a lower absorption of epidermal melanin. What about this one? What happened here? So we can see the burns because they use IPL laser, which is, again, not the most optimal laser for this skin type because you have a very wide wavelength, okay? What about this one? This is, again, a patient with IPL that was treated with IPL. But because they wanted to avoid the side effects, they used suboptimal energy. And when you use suboptimal energy, you actually stimulate the vellus hair and turn it into a terminal hair, which happened in this patient. What about this one? This is using CO2, which is not the best option. Again, we can use CO2 in darker skin, but we have to be very, very, very safe in this skin type. Otherwise, we will get scarring effect. So my next step is use optimal fluence, because you want to use the most effective, lowest fluence possible to reach your target end effect. Okay? So basically, if you use a higher energy, there will be dissipation of energy to the surrounding tissue, which will cause thermal hypo or hyperpigmentation and a pigmentary effect. And also the lower density. The thing with density, when you use fractional laser, is also very important, because if you use higher density, there also, again, will be a higher density of energy that will dissipate to the surrounding tissue. So if we want to choose between fluence and density, which one is more important, you think? Fluence or density? High fluence or high density? Let's say fractional laser. Acne scars. High density is most effective. Which one is associated with more side effects? High density, actually. They had a study on Chinese patients, 35 Chinese patients, and they had them on different treatments. One of, like, it was a split place or the randomized control, but they had high fluence, low density, and low fluence, high density. Which one developed more hyperpigmentation side effects? The ones with the high density and low fluence. So this one is dyspigmentation with 1064, again, with a higher fluence. Again, you can get hyperpigmentation with hair removal using. So this one is actually very common. So they might they use this the accurate laser, the perfect laser. They use the fluence that you usually used for this patient. What is different here? It's tanned skin, so you have more epidermal melanin. So you have more competitive absorption by the surrounding melanin, right? So you need, in these patients, you need to do one of two things. You either not perform the treatment, or you do the treatment with lower fluence. But there is also a chance if you do with lower fluence, you won't get the desired effect. The third one is using longer pulse duration, which is a given, because you have you want to use a pulse duration which is shorter than thermal relaxation time of your target. But here, we can see this very short thermal relaxation time of the small melanosomes of the epidermis. So you try to bypass these and use a longer pulse duration to target your, for example, the hair follicle, which you have. So, for example, if you're going to do Nd:YAG, okay, so the safest pulse duration would be around 35 milliseconds. If you use shorter than that, you have higher chance of affecting the small melanosomes and causing pigmentary hypo and hyperpigmentation. So number one, cooling, cooling, cooling. Cooling is very, very important. Whether it's a contact cooling, ice gel, ice packs, I need to remind you, like, try as much as possible to use cooling to spare the epidermis. If you don't use enough cooling, you will end up, even if you're using the right fluence, the right wavelength, the right pulse duration, without cooling, you might end up with pigmentation. It's not only, not only will decrease the pain, but it will also decrease the side effects. Number 5 is pre-post laser skincare, which is very, very important. I usually do pre and post laser skincare, and I think all of you do. This one study compared the petroleum with the sunscreen. We know the importance of sunscreen after treatment, but for how long should we give the patient sunscreen? We always recommend using sunscreen lifelong, right? But if patient is not very compliant, doesn't want, what's the window? What is the most important window for sunscreen? In this study, they actually compared petrolatum, which is Vaseline, with the sunscreen, and they saw the melanin index. We can see up there that the melanin index shoots up in the first week. Oh, sorry, what did I do here? So it's the first week. So you have the higher chance of getting pigmentation after laser in the first week. And then it goes down to the second week, third week. But let's say if you want to stress on the sunscreen, say please before laser and at least 4 weeks after using laser, according to this study. If the patient doesn't want, or if the patient is not very compliant with topical sunscreen, but it is very important, actually you can give them oral antioxidant, which is the polypodium locutomus, because it has shown that it doesn't only prevent the ultraviolet-induced effect, it also helps with the visible light, which is very important in patients with melasma. So polypodium locutomus in a 480 milligram daily might help complement the effect of topical sunscreen. We also need to mention the effect or the importance of using anti-inflammatory agent like steroids. This one used clobetasol, which is a very potent steroid, for 2 days after treatment, and patients who used steroids had a very low risk of PIH, okay? But for how long should we use the steroid? Would it affect the wound closure? Would it affect the healing? In this study, it didn't actually affect. It was the same time period between the petrolatum and the clobetasol. In this another study, they had also added tacrolimus that showed that it can modulate the melanogenesis and the scar healing. And if you see in this graph, this is the wound, okay? And this is the wound area reduction. You can see the steroid and the tacrolimus had exactly the same speed of healing. And then you can see the diverse here. It was slower with the steroid. So if we want to give the patients, our patients, steroid, we would recommend, actually, according to this study, another study, 2 days is a good period. After that, it might affect or slow the wound healing. But can we actually predict the post-inflammatory hyperpigmentation in patients if we just omit the skin type? Because we see people with lighter skin type that will develop hyperpigmentation, right? And vice versa. There are people with darker skin types who never develop hyperpigmentation in procedure. So in this study, they have a theory on more than 100 patients that you can actually predict it by looking at the patient palmar creases. If you see the pigmentation in the palmar creases, they had 2 groups of patients. This is on the left-hand side and the right-hand side. These patients had lower risk, according to the study, for post-procedural hyperpigmentation, while the other ones had higher risk of post-procedural hyperpigmentation because they had darker pigment in their palmar creases. And we can see that actually it matches. The post-procedural hyperpigmentation can match the pigmentation in their palmar creases. And another one, and it's not related always to the skin type, because we see a one here with skin type maybe 2. She had also some pigmentation in her palms, while this one with skin type 4, no pigmentation, so she has lower risk of post-procedural hyperpigmentation. But what about hypopigmentation? Can we treat it? It's one of the most difficult things to treat, right? Like this one. So what has shown to be actually effective is bimatoprost. You know bimatoprost, that is used to elongate the nail. It's a prostaglandin agonist. It actually has an effect on tyrosinase, so it stimulates the melanogenesis. But if you combine this with CO2 laser, fractional CO2, very superficial CO2 to reach 200, let's say 20 to 140 microns to reach the epidermal melanocytes, and then give bimatoprost for 7 days, because we know the opening after CO2 can last up to 7 days. So you're reaching the basal melanocyte, stimulating melanogenesis, and then maybe give the patient tacrolimus for another month. You will get actually a nicer effect like this one. See, this is before, and this is after. Impressive. Okay? So this one, just to show you that radiofrequency can actually be an effective method of treatment in patients with darker skin types. So in conclusion, so what I usually do, pre-procedure SPF is very important. You can treat or prepare the skin with bleaching agent, whether you're using hydroquinone, glycolic acid, kojic acid, thiamidol for 2 weeks or more. During procedure, try to use longer wavelength, lower fluences, and longer pulse durations. And if you're doing resurfacing, lower density with epidermal cooling, and try to do slower treatment speeds to allow some time for epidermal cooling. Post-treatment, SPF is also important, at least for 1 month. Moisturizers, bleaching the skin for 2 weeks, again, or longer can be needed, and post-treatment potent steroids. Go for potent steroids, but not for a long time. 1 to 2 days are usually, or 3 days. Maximum is more than enough because you don't you want it to affect the healing of the skin. And this is another algorithm that was published in patients of skin of color that you can take a picture of. It's very useful. And that was all. Thank you.